I am Dr. Hatim Husain from the University of California, San Diego. In metastatic EGFR mutation-positive non-small cell lung cancer, I choose first-line therapy with the intent of extending a patient's time without disease progression. Osimertinib has truly become standard in first-line metastatic EGFR mutation-positive non-small cell lung cancer. It's demonstrated tolerability and compelling efficacy. While the patient is on therapy, I'm also thinking of putting a plan in place for subsequent treatment. Not all patients progress at the same trajectory. The number of sites of disease and the kinetics of progression are important for defining the next line of therapy. As is commonly done in metastatic EGFR mutation-positive non-small cell lung cancer, a repeat biopsy may be considered. Here's a real-world situation about what happens when the time comes to choose a second-line therapy, as I see in my practice and you'll likely see in yours. Harold initially came in with a lung adenocarcinoma and bone metastases. Comprehensive biomarker testing showed an exon 19 EGFR sensitizing mutation. He was treated with first-line TAGRISSO. Harold was on first-line TAGRISSO for 19 months, until a routine scan revealed radiologic progression in a single bone lesion. Harold was offered the chance to participate in a clinical trial, which he declined. Harold and his oncologist reviewed the guideline-recommended treatment options for second-line therapy. These include single-agent or combination chemotherapy, depending on a patient's performance status, chemotherapy plus anti-VEGF therapy, or chemotherapy in combination with both IO and anti-VEGF therapy. Together, Harold and his oncologist decided on a combination chemotherapy for his second-line strategy. Harold's case demonstrated the value of first-line treatment with osimertinib and also illustrates some of the options available to patients upon progression. At each stage, Harold's treatment was precision-oriented and specific for his individual needs.
Indication: TAGRISSO is indicated for the first-line treatment of adult patients with metastatic non-small cell lung cancer, NSCLC, whose tumors have epidermal growth factor receptor, EGFR, exon 19 deletions, or exon 21 L858R mutations, as detected by an FDA-approved test. Important safety information for TAGRISSO. There are no contraindications for TAGRISSO. Interstitial lung disease, ILD, pneumonitis, occurred in 3.7% of the 1,479 TAGRISSO-treated patients. 0.3% of cases were fatal. Withhold TAGRISSO and promptly investigate for ILD in patients who present with worsening of respiratory symptoms, which may be indicative of ILD. For example, dyspnea, cough, and fever. Permanently discontinue TAGRISSO if ILD is confirmed. Heart rate-corrected QTc interval prolongation occurred in TAGRISSO-treated patients. Of the 1,479 TAGRISSO-treated patients in clinical trials, 0.8% were found to have a QTc greater than 500 milliseconds, and 3.1% of patients had an increase from baseline QTc greater than 60 milliseconds. No QTc-related arrhythmias were reported. Conduct periodic monitoring with ECGs and electrolytes in patients with congenital long QTc syndrome, congestive heart failure, electrolyte abnormalities, or those who are taking medications known to prolong the QTc interval. Permanently discontinue TAGRISSO in patients who develop QTc interval prolongation with signs or symptoms of life-threatening arrhythmia. Cardiomyopathy occurred in 3% of the 1,479 TAGRISSO-treated patients. 0.1% of cardiomyopathy cases were fatal. A decline in left ventricular ejection fraction, LVEF, greater than or equal to 10% from baseline, and to less than 50% LVEF occurred in 3.2% of 1,233 patients who had baseline and at least one follow-up LVEF assessment. In the ADAURA study, 1.5%, 5 out of 325 of TAGRISSO-treated patients experienced LVEF decreases greater than or equal to 10% from baseline and a drop to less than 50%. Conduct cardiac monitoring, including assessment of LVEF at baseline and during treatment in patients with cardiac risk factors. Assess LVEF in patients who develop relevant cardiac signs or symptoms during treatment. For symptomatic congestive heart failure, permanently discontinue TAGRISSO. Keratitis was reported in 0.7% of 1,479 patients treated with TAGRISSO in clinical trials. Promptly refer patients with signs and symptoms suggestive of keratitis, such as eye inflammation, lacrimation, light sensitivity, blurred vision, eye pain, and/or red eye, to an ophthalmologist. Post-marketing cases consistent with Stevens-Johnson syndrome, SJS, and erythema multiforme major, EMM, have been reported in patients receiving TAGRISSO. Withhold TAGRISSO if SJS or EMM is suspected and permanently discontinue if confirmed. Post-marketing cases of cutaneous vasculitis, including leukocytoclastic vasculitis, urticarial vasculitis, and IgA vasculitis, have been reported in patients receiving TAGRISSO. Withhold TAGRISSO if cutaneous vasculitis is suspected. Evaluate for systemic involvement and consider dermatology consultation. If no other etiology can be identified, consider permanent discontinuation of TAGRISSO based on severity. Verify pregnancy status of females of reproductive potential prior to initiating TAGRISSO. Advise pregnant women of the potential risk to a fetus. Advise females of reproductive potential to use effective contraception during treatment with TAGRISSO and for 6 weeks after the final dose. Advise males with female partners of reproductive potential to use effective contraception for 4 months after the final dose. Most common, greater than or equal to 20%. Adverse reactions, including laboratory abnormalities, were leukopenia, lymphopenia, thrombocytopenia, diarrhea, anemia, rash, musculoskeletal pain, nail toxicity, neutropenia, dry skin, stomatitis, fatigue, and cough.